Good evening, everyone. You're welcome to find a seat and join us. My name is Michael Clark from Johns Hopkins University School of Medicine and the American Society of Pain Educators. On behalf of my faculty colleagues, the PAINWeek staff, and all of us who work to develop this program, I'm pleased to welcome you to the 10th Annual PAINWeek National Conference. How about a round of applause? Before we get started this evening and take you into some of the other events that will happen, we're going to take the bull by the horns and ask you, our frontline practitioners, what would the world look like without opioids? We asked this auspicious question to our PAINWeek faculty a few seasons ago, and this is what they had to say.
Right now, I don't know that we are seeing sufficient monitoring of people. Most certainly, people who could benefit from opiates are not receiving prescriptions for various reasons, including fear of the prescriber of somehow being scrutinized for doing so. And at the same time, individuals are being prescribed who may be the worst candidates for opioid therapy.
In my world, in women's health and chronic pelvic pain, I don't think that it would hurt me all that much if opioids were not here, because we already know that they unfortunately don't help patients in the way we need them to. So I would be focused, without having opioids in the world, on more neuropathic medication treatments.
I think that possibly could bring the healthcare system to its knees when you consider 100 million people suffer every day with chronic unrelenting pain, and to not have the opioids as a tool in your toolbox would be a devastating blow. I do think, however, though, that practitioners today have to be equally well-versed at the therapeutics of pain management, which includes the use of non-opioids and adjuvant drugs, certainly.
I do travel quite a lot, and there are many countries where opiates are not available for the treatment of any pain, actually, and I don't think that's a good thing. But the chronic pain patients do just fine because they don't expect to get opiates. They do other things, particularly in Asian countries where it's normal for older patients as they age to exercise more and to do more Tai Chi and to do more meditation, relaxation. That's how they expect to treat their pain.
Well, in a world in which opioids did not exist, I think that we would see more people worse off than better. I think that we can say in some settings, we've seen this experiment. There have been and still are countries in which opioid access is very poor or severely restricted and overmanaged. What you see in those countries is really a lack of good pain management.
We need opioids. The solution is not to get rid of the opioids. The solution is to teach the people in training how to use them, how to assess patients, how to determine who's an appropriate candidate for them, and to know how to monitor them along the course of therapy.
You know, I was there before we used opioids to any extent, and I actually was one of the people that thought that we needed to really consider how to use these with people with non-malignant pain. And the suicide rates were incredible in the field. People gave up. They felt overwhelmed. We offered them very little. Opioids were a miracle, and always have been. I think a world without them would be devastating for the people who live with persistent pain, and there are quite a few of them.
I think society has to come to grips with the realities that drugs are misused, and the balance between a therapeutic agent and a poison is often dose, as has been said many, many years ago. All things are poison. It's only a matter of dose that determines whether they're therapeutic or not. And I think we have to struggle to bring the balance in the use of opioids back into appropriate context.
Indeed, and now we are here to figure things out and uncover answers and insights over these 5 days of PAINWeek. Needless to say, it's a watershed event, and it is worth looking back for a moment on how far we have actually come in the delivery of pain education and pain management. Thinking about just this meeting, from roughly 400 attendees who participated in 2007, PAINWeek has grown to the largest and best recognized national forum on pain management. To deliver this year's curriculum of approximately 140 hours of course offerings, we've assembled over 90 pain management thought leaders. That growth and success is largely a testament to you, our conference attendees who are dedicated to working on the front lines of patient care and who have resolved to accept the challenges posed by this significant public health crisis, the management of chronic pain. This week, roughly 2,300 of you have joined us for the experience, and we applaud your commitment to navigating the difficult world of pain care delivery. This really is the largest attended event in the United States when it comes to pain management and pain education. Those difficulties, as outlined in that opening video you just saw, are amply evident to all of us. If you take care of patients, you hear all of those statements, you run into all of these issues. The crisis of abuse and misuse of both prescribed medicines and illicit substances is alarming in both scope and escalating trend. Regulatory reaction to it but there are still the needs of 100 million patients with pain and the need for appropriate engagement of opioid therapy in their treatment. In this year's curriculum, we devote particular attention to these concerns, and you'll find the issues raised by opioid prescribing considered in many of our own program tracks from a variety of perspectives. They are not the panacea. They are not the scourge of the earth. It is a question of finding a virtuous path with a very difficult set of challenges. We think you'll come away with a better preparation in the skills of risk assessment, patient evaluation and monitoring, analgesic selection and titration, record keeping, and practice compliance, and in the other tools of multimodal pain management that we all want and need for our patients and ourselves. You know the most potent molecule we have in our treatment armamentarium isn't anything new. It's the relationship we establish with our patients. And as my colleague Kevin Zakharoff observed in his presentation earlier today, patient-provider communication backed by competence and confidence in what we are practicing is the real key to guiding our patients with pain to a better quality of life and outcome. If you're a PAINWeek veteran, you'll notice much more that's new at the conference this year. There are new course tracks in acute pain management, chronic pain prevention and care, functional pain syndromes, pain management in the emergency department, women's health, and courses for the advanced practice provider. Among the offerings in our always popular special interest sessions are new topics on botulinum toxins as neuromodulators, advances in pharmacogenomics, a provocative question about the medical Stasi as risk management for controlled substances destroying the provider-patient relationship, and a lively debunking of one of the current underpinnings of opioid decision-making called the med myth, look it up. To enable you to sample a greater range of our diverse curriculum, we have made available PAINWeek on demand, where you can not only view all of the conference content, but you can also earn additional continuing education credits. Attendees can find the on-demand team at the registration desk on level 3.
We welcome our participating organizations back to PAINWeek and look forward to full-day programs presented by the National Association of Drug Diversion Investigators, the American Society of Pain Educators, the American Pain Society, and the American Academy of Pain Medicine on the remaining days of this conference. And finally, with respect to the week's agenda, don't forget to check out the exhibit hall, which opens this evening and will remain open tomorrow and Friday. You'll notice something new in the exhibit hall this year, an area that has been designated as our Expert Opinion Live. It will feature 5 scheduled 20-minute, timely, and relevant discussions on topics ranging from chronic assessment tools to pharmacogenomics and the promise of virtual reality. There's also our scientific poster session and reception tomorrow, and the poster podium presentations on Friday. The Global Education Group is the accredited provider for PAINWeek, and we would like to thank them for doing a superb job on managing all the content development for this conference. I think if you have been to any other conference in the world, you will acknowledge that this conference is one of the best organized, best run, most exciting and engaging in terms of its artwork and the people that work within the organization. So I'd like you to give them a hand too. And of course, conferences like PAINWeek cannot be produced without the support of the health sciences industry. And we would like to thank all of our commercial sponsors, especially our diamond sponsor, Teva Pharmaceuticals, our platinum sponsors, AstraZeneca and Kaleo, and our gold sponsors, DSI and Quest. We would also like to thank Haymarket Media for providing an enormous amount of support and visibility and publicity for the conference. Each year, the Pain Scholarship Program seeks out committed and deserving practitioners from across the country. There are thousands upon thousands of them, but this year we're awarding 6 scholarships to the conference based on people's insights and inputs about care of patients with pain and their education surrounding that care. I'd like you to welcome me now, or join me in welcoming now, Dr. Kevin Zakharoff, who will speak about the award recipients.
Thank you, Dr. Clark. And it is my 10th year at the 10th PAINWeek, and I'm very happy to have been a part of making this conference what it is today. I'm really proud of it. I think we do a lot of work to prepare our presentations for you, but nothing really makes me feel to the core the sense than what I'm about to read to you now, which are some excerpts from some of the essays that we received. Because I think what you and your peers think is actually most important to keep us in line and on track. If you had asked me during my first pharmacy residency training year to discuss the role of pain management pharmacist, I probably would not have had an answer. Or, as is more common, the answer would have been confident and far off the mark. Nevertheless, pain was present in all areas of my PGY1 year, in practice in both inpatient and outpatient settings. Perhaps most surprising to me was the lack of preparation I received from pharmacy school prior to entering the world of pain. I could recite all of the blood pressure medications and how they worked. I could convert someone to long-acting insulin and start them on a nausea chemotherapy regimen without any problem at all. However, ask me which opioids were helpful for the treatment of neuropathic pain, and I was at a loss. The media and pop culture paints the picture of drug-seeking individuals that will do whatever it takes to obtain opioids. But I quickly learned through a year at the VA that this is only a fraction of what I call the pain epidemic. Yes, we need to be concerned about addiction, abuse, and misuse, but we should also be concerned about the large population of untreated pain patients. Attending PAINWeek would certainly help me fulfill my need to acquire knowledge of analgesic advancements. However, of more importance to me is that attendance will support my desire to enhance my educational approaches related to pain management so that I may become most effective at providing my students with the best possible understanding of pain and its treatment. Our students are our future providers, and the more and more I can do to teach them and instill in them accurate and compassionate views of patients with pain, the more effective we can be as a pain management community. Pain management is vital in every clinical practice, as pain has no guidelines, has no socioeconomic status, or has no demographic criteria. Pain is a worldwide epidemic and an exponentially growing problem. It is not uncommon for our patients to express that they feel that they have been suffering in silence and that they feel that most medical professionals do not seem to understand what they were experiencing until coming to our practice to see us. They typically lack an understanding about chronic pain and that life can go on despite having chronic pain. The lack of general education and training for occupational therapy practitioners like myself and other medical and psychology practitioners, as well as the shortage of qualified pain specialists, most likely has contributed to underserving of this population. And lastly, from our winner of the scholarship program, our grand award winner, I'll read this. Pain. It unites people with rheumatoid arthritis, metastatic lung cancer, chronic obstructive pulmonary disease, fibromyalgia, ankylosing spondylitis, and other complex diseases. Pain keeps people awake, traps them in bed, and imprisons them in their homes. People who live with poorly managed pain miss out on life, in part because they are too much in pain to leave the house. But in some cases, they fear what might happen if they experience a pain crisis away from home. When discussing a patient's goals of care, I have been impressed when they talk of wanting to be able to do things like folding the laundry, emptying the dishwasher, going for a walk around the block, or just feel well enough to attend a child's soccer game. There is one principal barrier to pain management: education and training in my practice. One of the most formidable barriers to pain management includes government and society, who more and more seem to equate pain management with opioid overdose and abuse. My educational and professional goals are to deepen my understanding of complex pain and different treatment approaches. When meeting a patient, I want to be able to offer that person a solution to his or her pain problem. At the end of the day, my education and training may be a tool to help improve a patient's overall quality of life. I couldn't have written stuff like that. So if you're here, please stand to be recognized. The winners are Jacqueline Pratt-Cleary, Jane Palasauskas, Lori Goulman. If you're not here, we're clapping for you. Kimberly Bradeen, Leslie Dixon, and our first place essay winner, Mary Bronwyn Long. Thank you very much.
Thank you, Kevin. Every year, Pain Week and the American Society of Pain Educators recognize individuals who have contributed in substantial measure to frontline pain education. This year, the American Society of Pain Educators has chosen Dr. Paul Cristo, Associate Professor in the Division of Pain Medicine at Johns Hopkins University School of Medicine, as our Pain Educator of the Year. Let's give him a round of applause. And PAINWeek is pleased to recognize Dr. Jeffrey Gooden, Director of Pain Management and Palliative Care at Englewood Hospital and Medical Center, as the Pain Practitioner of the Year. Congratulations to both of you. And this year we also extend recognition to Brent Snodgrass, a family nurse practitioner at LifeLink Pain in Memphis, as our Advanced Practice Provider of the Year. So these are just exemplars of what we're all doing, all trying to do better with, and we're pleased to acknowledge them. You see here in some of these headlines, and based on what you've been hearing at this meeting and also just this evening, that this is a difficult time. We live in a land of plenty. Plenty of people, plenty of problems, plenty of stuff, but also plenty of opinions, plenty of innovations, and we have, thankfully, plenty of freedoms. So I want you to think about how it is that you can have a voice and how that voice will be recognized. Because where else in the world could you have some of the things that happen in this country, and yet we continue to move forward, we get better, we do things that help people, and we make progress. If you've participated in other PAINWeek conferences, our keynote speaker will need no introduction. He's among our most dynamic and insightful faculty presenters, and it's with great pleasure that I ask you to join me in welcoming Dr. Stephen Passik to deliver the PAINWeek 2016 keynote address. Thanks.
Thank you very much. It's just a pleasure to be here with you. I'd like to thank the organizers of PAINWeek for this opportunity. And I'm just delighted at the turnout. I actually didn't know there were still this many people in pain management. But I trust if you were allowed in here, your MSc level is below 120. And this year, the title of my talk is X. It's not what you think. We had something else in mind at one time, but how do you top Jesus, bacon, and hyperalgesia? Or the iceberg cometh? Or a range of other topics that I was given over the years. And I'm here to talk to you today to continue to try to help you and advocate for you and keep you feeling a sense of fellowship with all these other people in this room, because treating pain in today's world can be a very isolating experience. You sit there in an Orwellian world where suddenly everybody has turned against what you're trying to do. You went into this to help people, to relieve human suffering, and suddenly people are looking at you as if you're some kind of a drug dealer or a criminal. And it changed kind of overnight. And we have really two problems on our hands. We have this terrible, terrible problem growing every day of chronic pain, and we have a problem with opioid overuse, abuse, diversion, overdose, and death. And we have to solve it. For the good of our patients, we have to solve it. Some people probably looked at the CDC guidelines. Opioids don't work. It's your get-out-of-jail-free card. I can now say, listen, the government doesn't want me to do this. I'm done. That's not the people in this room. And so hopefully we'll take a little bit of a different look at it. And I want to show you some studies and some facts and some factoids that disappeared into the ether that maybe will arm you and steel you to help you continue to face the onslaught and continue to try to do what's right for your patients. And I applaud you. My hat is off to all of you that you're still in there fighting every day, trying to do what's right for people. The views expressed by me today are mine alone. They're not those of my employer. Some of you may know I did this. I was where you are. I did what you do, and I did it for 25 years. I did it at Sloan Kettering and Vanderbilt and a range of other places. I worked as part of an expert team, and I can tell you, I'm proud to say, I did it for 25 years. We had often very, very good outcomes. I had no lawsuits, no suicides, very few people spin out of control into unchecked addiction because we tried to do it right, despite all the things that mitigate against trying to do it right. And that kind of thing is lost. These are not, in much of the dialogue today, these are not the opinions of Endo Pharmaceutical. I'm not here representing my employer. Most of the people, my colleagues in the room who I work with, are the ones you'll recognize them. They're all wearing fake nose and glasses right now. And they will be stealthily sneaking out of the room as I get more and more controversial. I would also like to say thank you to Jeff Fuden, Nab Dasgupta, Bob Twillman, Lynn Webster for their help in helping me put this talk together. Because I basically surveyed all of my buddies through email about what are some of the myths about opioids that bother you the most? What are some of the things that you know are untrue that you hear every day? And I wanted to include some of those in this talk for you today. You know, there are a lot of sensitivities. I realized I didn't want to get up here and sound like a jerk. It's hard to question some of the key assumptions that you read about and hear about in the media every day. It's hard to question the interpretation of data and fight back when untruths are hurled at you about opioids. It's hard to ask for a sense of proportion even. When I show you in a moment some data, North Carolina has some very, very good epi data thanks to Nab Dasgupta, one of the architects of Project Lazarus. By the way, an example of a program in a state where they were able to lower opioid overdose deaths by 70% without putting any downward pressure on opioid prescribing. It can be done, and they did it in North Carolina. And when I show you some of those data, and you see how many people overdosed and died who actually had a prescription, and you say to yourself, we are living in an Orwellian time when you can't convince people that we have lost all sense of proportion in this debate. But at the same time, I say that we have to do it, but we cannot appear, I don't want to appear callous. I don't care if it's 1 in 100 people who has an unfortunate event and dies. Every opioid death, whether it's to illicit opioids, whether it's to prescription opioids, whether it's someone who had a prescription, whether it's somebody who took a prescription out of their grandmother's dresser drawer, everyone is a tragedy. Everyone leaves behind scarred people. Somebody close to me, essentially my daughter's stepbrother died of an opioid overdose, a young law student with everything to live for. Every one of them is a horrible tragedy. And I'm not callous to them. And I also don't feel virtuous, and no one should, and I know no one in this room does, if you hear that it's shifted over to heroin and people are dying of heroin and not oxycodone or hydrocodone. That doesn't make anybody here feel virtuous. The idea was not to push it from one kind of opioid to another kind of opioid. Every death is a tragedy. And as I look at this situation, I don't feel like I want solutions that address one side's pain over the pain of the other side. That has been what's been going on from the very beginning, because for every complicated problem, there's a simple solution, and it's appealing because it's simple. And as simple as it is, generally wrong. And I feel like the way we have approached this as a law enforcement problem or as everything but a public health problem from day one, the solutions have been somewhat misguided, looking for shortcuts for what is otherwise an extraordinarily complicated problem. So I start this talk, as I have so many over the years. Doug Gorley's in the room. Doug is one of my heroes in all of this, and I have a reference to something that he said here. But I show this to you today. I've been showing the opioid pendulum for 25 years. Where are we now between opiophilia, somebody said that was their aunt's name, opiophilia, and opiophobia? If opiophobia is 1946, when the president of the AMA said, spare your terminally ill cancer patients the indignity of morphine addiction. And if opiophilia is 2005, when we basically were running around saying we need to liberate opioids. We've got to put everybody on opioids. Pain will be vanquished, and we'll all walk off into the sunset happy, maybe a little more constipated. Right? Where are we now? Is it 1953? Where have we gone back to? I cannot believe how pain patients are taking it on the chin virtually every single day. The opioid epidemic is all anybody refers to. What is the opioid epidemic? After 25 years of expanding opioid prescribing, what does everybody in this room feel that we've learned? Did we learn something fundamental about the clinical use of opioids? How many times do I start reading an article that's basically anti-opioid that starts out, about 15 years ago, the drug companies and the doctors who represented them, they were all out there telling us, you got to use more opioids. Nobody will get addicted. We have to use more opioids. We did it. It didn't work. So we're not doing it anymore. That's how the articles start. I would tell you, I think we were extraordinarily successful in getting people to use a lot more opioids. Most of the commonly used opioids went up 400% and 500% in that time period, from the mid-90s to the mid-2000s, right? So we got them to use more. Did we do it well? I don't think we did it well. Doing it more doesn't necessarily mean doing it well. Did we ever raise the standard of care? Did we ever decide that we were going to give doctors enough time and enough knowledge and enough training and enough reimbursement to do it right and see complex patients for longer than 8 minutes once a month, the minimally monitored model that dominates the day? How many people does a 1-month visit, how many people can manage a month's supply and get no psych, no monitoring, no PT, no alternative, no integrative, and do well? There's about 4 people. No, actually, it's a lot of people. Maybe it's 30%, but it's not everybody. And when you take that same model and that's how you deliver opioid therapy to a polysubstance abusing, traumatized young veteran just back from the Middle East who had his leg shot off, who has PTSD and maybe TBI and all kinds of other problems, and you deliver care in that same kind of a way, what do you have? You have a recipe for a public health disaster. And did we really, there were models of excellence, I'm going to show you some. But did that ever become the standard of care? Did we ever actually raise it? So I'm here to say, I think we did a lot of opioids. I think to me the jury is still out. I think what we learned is what's wrong with our healthcare system, not what's wrong with opioids. Where does our healthcare system fail? It fails with chronicity. We've turned every disease under the sun into a chronic disease. And we don't know how to deliver care to chronic people. We make care more difficult to access, supportive services, psych, etc., more difficult to access the longer you're sick. Does that make any sense? Chronic pain, we don't recognize that what constitutes improvement in people with chronic conditions is sometimes a flat trajectory. How many people do you give any kind of pain treatment to? The patients that you guys see, many of them have physical illnesses, the lifetime trajectory of which looks like this. They have psychiatric disorders, the lifetime trajectory of which looks like this. And you're going to give them an oxycodone and it's going to turn into this, right? It's going to basically turn everybody around. What if we turn this into this or this? Is that not progress? Oncologists are happy to give drugs that cost $8,000 a dose to level people off. We have an equally fatal disease here in many instances. And if people don't become art dealers as soon as we give them opioids, it's not considered worthwhile. We don't know how to deal with conditions that have major motivational and psychiatric components very well in our healthcare system. And probably the biggest thing that got exposed was our inability to coordinate care. Everyone, Doug and Howard and others have talked about the primary care doctor or somebody else being the hub of the wheel and getting other consults and bringing those to bear in the life of the pain patient and talking to each other. When I was at Vanderbilt, I had 30 patients, 35 patients a day. I prayed for no-shows. If I didn't get a no-show, I couldn't pee. If I didn't get 2 no-shows, I couldn't pee and eat. And I'm trying to communicate back to doctors who are seeing 40 and 50 patients a day. And we're supposed to coordinate care. Or maybe the electronic medical record will take care of it for us. They really help with medical communication, don't they? Nowadays, note writing used to be an art form. You used to pick up a chart. It was a communication amongst professionals who are coordinating, who are working together to help each other understand what each were doing and communicate something about the patient. Now it's all dropless. Everybody has the same note. And the notes aren't written for your colleagues and other people taking care of the patient. The notes are written for the insurance company and the lawyers. So there's no medical communication. Nobody has time. The note writing is a lost art. Best note I ever read. When I was at Sloan Kettering, I get called to the breast cancer service floor, and I'm called by a sort of a fiery oncologist who didn't call very many psych consults. And so I get to the floor, it was those old handwritten flip paper charts, and I get called to the floor, and I figure, wow, this man, he doesn't call too many psych consults. I better read this chart and know who I'm going to see before I go in there. And I flip to a page, and there, written in his distinctive handwriting across the entire page, is "Call Steve Passik, this family is a Freudian picnic." Now, not the most professional communication I ever read, but it spoke to me. I got it. He was upset. That kind of thing is gone, and we don't coordinate care. The left hand doesn't know what the right hand is doing, and in that setting, and you introduce a substance with diversion value and other problems, we have problems. We have a need for ongoing risk assessment. Doing the initial risk assessment is hard for people. Doing it in an ongoing way, and I had patients, as many of you probably do, who took their opioids in an adherent way over many months, and then they lose their job, and all of a sudden they come in asking for their opioid script 2 weeks early. And if everything was going well and they had a half-hour visit or a 20-minute visit scheduled that day, how many of you can do that complex assessment that quickly? That wants more opioids. Why? Because he's anxious? Because he's depressed? Because he's selling it to make the rent money? Why? Who has the time to do that assessment, not just once, but over and over again over the course of maybe years? Our healthcare system doesn't allow for it. Into that mess, we introduced 400 and 500 times the amount of opioid. And needless to say, we ended up with a problem. So what's an epidemic? The word epidemic is a really good word to use if you want to pass legislation, rally the troops, get people upset, right? Get them motivated. Every single day, epidemic is in the papers, on TV. Does epidemic have a precise definition? An epidemic occurs when a disease affects a greater number of people than is usual for the locality, or one that spreads to areas not usually associated with the disease. You get that? Let me highlight two important features. Greater number of people, areas not usually associated. Does the opioid epidemic meet those criteria? Epidemics are about expectations and geography. Okay? Is chronic pain an epidemic? Is it still an epidemic? It's a question. If we all know that we're all getting older, some of us are getting a little heavier, getting more diseases associated with chronic pain, we expect a lot of people to have pain. Maybe it's not an epidemic. It doesn't violate expectations. Is opioid abuse an epidemic? Well, how about expectations? I can go back to those days, in the early days of when opioid prescribing was first taking off, and I can remember the zeal. It was a religious movement. It was not a scientific movement. It was a religious movement. People were on a mission, and they believed what they wanted to believe. And listen to this. Shortly after opioid prescribing started to take off, does everybody know what ARCOS is? ARCOS is a system that registers quotas. Drug companies have to ask the DEA, how much opioid can we manufacture this year? And that was going up in an unprecedented way through the 90s, because it had to keep pace with prescribing. And I remember a paper that I think was in the New England Journal of Medicine at the time, about 2 to 3 to 4 years after opioid prescribing first took off. And it was like gleeful, because we said, see, we told you nobody was going to get addicted. Remember the less than 1% stuff that people used to say? You remember Porter and Jick, or should I say John 3:16. You remember that paper. I'll come back to it in a minute. But we basically said, there's no risk. No one's going to get addicted. We need to liberate these drugs. And there was a paper that came out that said, look, ARCOS is going up. The Drug Abuse Warning Network, though, DAWN, is flat. And everybody wanted to believe it. And they did believe it. They believed that we could quadruple or quintuple prescribing with no concomitant abuse happening. And everybody bought it. Of course, in retrospect, it was too soon to tell. Other social forces came in. Other issues, diversion started to happen. And of course, it caught up and then surpassed it. But think about, was the healthcare system ready to be flooded with opioids? Again, expectations. We're running around trivializing addiction, trivializing abuse and diversion, and expanding prescribing with not the most intellectually honest approach to it. And at the same time, look at the system. Only Kentucky had a prescription drug monitoring program. I was there in Kentucky when sustained-release oxycodone was first exploding a bit in southeastern Kentucky. And, if you wanted to know if your patient was maybe double-dipping and going to multiple docs, you had to send a fax to Frankfurt, and then they would fax it back to you when they felt like it, and you'd get it, and then you would read it, and get this, by law, you couldn't share it with the other prescribers listed on the report. You couldn't put it in the patient's chart. It wasn't real time. It took forever to get back to you, and you couldn't communicate it to the other people that were duplicating prescribing. So the only state in the country that had one was the seat of the beginnings of the abuse crisis, because it wasn't functional. So there were no PDMPs. Now, how many states have PDMPs now? 49. And, utilization is up because they've regulated it to be up, because you can't write in some states unless you check it every time. I'll never forget when I first moved to Tennessee, they were about to pass the law that if you were going to write an opioid, you had to check the system every patient, every visit. And they wanted me to help advocate for that. And so they called me up. I knew they were going to call. I think Jen told me they were going to call. And I get this call. Hi, Dr. Passik. This is Kevin Crawford, Tennessee Department of Homeland Security. And I said, I'm sorry, did I forget to register as a Hebrew living in Davidson County? In Tennessee, it was under the Department of Homeland Security. And I said, son, have you ever been to a doctor? Every patient, every visit? I could see when a new script is happening, a new patient, something. We used to have to do it for an hour of unreimbursed FTE time every single clinic day to catch nothing. Because as a criminal element, they're very valuable, but they're just not valuable when they're forced down everybody's throats. When you start creating hours of unreimbursed FTE time, people say it's too much trouble, I'm not going to write anymore. And some part of me, the cynical part of me, wants to believe that that's why it happens. Only Kentucky had a PDMP. Abuse deterrence and better opioids were science fiction at the time. LCMS drug testing took 2 weeks to come back. There were no give-back programs. Right? So the addiction training wasn't common then. And into that system, with all those other problems, we didn't get anybody ready for the influx of opioids. But we walked around trivializing addiction, so people got caught by surprise, hence an epidemic, because it was more than expected. What about geography? Chicago Tribune and the Atlantic, a headline from Buffalo Grove, from the community, a heroin epidemic is invading our suburbs. When heroin hits the white suburbs, suddenly it's not a crime problem, it's a health problem. So part of me, the cynical part of me, understands that where pain politics are concerned and opioids and riling people up, white lives matter. When the cynical side of me started working in a methadone maintenance clinic in East Orange, New Jersey, in the early 80s when AIDS was first coming in, and I can tell you that when addiction was largely a problem of inner city people of color, people were not bent out of shape. When kids in suburbs started to die, all of a sudden we regulate the daylights out of it. And I don't think you can sit back and ignore, to some extent, the racial aspects of what this overreaction has been all about in terms of regulation. So, do we have one epidemic or do we have two? Prescription opioid abuse, extremely costly, 16 to 19,000 overdose deaths every year, 20 to 120 billion dollars in cost per year. Chronic pain, 100 million, 30 million, 70 million, who knows where it is, 20 to 25 to 39 million with daily chronic pain, 10 million disabled, extremely costly, double the suicide risk because of chronic pain. And I want to bring your attention to the fact that, how many of you read Lynn Webster's column where he wrote about the fact that he thought the CDC guidelines were going to lead to a rash of suicides? Did any of you see that? Do you know what's happened since Lynn Webster wrote that? He wrote to me asking for my help because he's getting suicide notes written to him. We have two big epidemics. We have two problems. We need to solve this problem and do it with complex public health solutions, better drugs, better practice, not simply constant downward pressure on prescribing. That seems to be legislators and others, that's the only thing that they can really impact. Because you guys are kind of alone, you know, you don't have time to, you're in your practice up to your eyeballs because you're getting all the patients that nobody else wants to treat anymore. Who's going to fight with them about this stuff? And they keep exerting pressure where they can on opioid exposures. So you're in there trying to walk this tightrope. They want you to see 30, 35 patients a day. They want you to be now a cognitive psychologist. And I'm not talking to the psychologists in the room. They want you all to be cognitive psychologists. Cognitive psychologists don't get paid to be cognitive psychologists. And they want you to be cognitive psychologists. They want you to do psychotherapy in your 8 minutes. And also size up risk and count the MSCs and do all the other stuff. Check the PDMP, get the urine drug test, do it all, and do it quick because you got about 50 more people sitting out in your waiting area. That's what chronic pain practices become. And what do they do? They tell us that opioids don't work. So there's a deep divide. Opioids don't work. Look at the low back pain meta-analysis. I mean, I and my colleagues at Endo, we sit around, we try to design an opioid trial that looks at more than just a pain score. And I mean, it is a matter of some embarrassment as a former pain researcher that we don't really have an endpoint for these trials, but somehow the meta-analysis spoke to everybody that opioids don't work, or they don't work for long. On the other hand, we don't have a lot of long-term data about opioids do work, but I am sick to death of constantly being told that there's no evidence. First of all, we are in Vegas. 50 million Elvis fans can't be wrong. After all of the pressure, there are still nearly 1 million people on OxyContin alone. They're not all about to die. They are not all addicts abusing. They're people trying to live their life. There are people who respond to opioids. I used to fight with Joel Saper about this years ago because Joel was running a tertiary care headache clinic in Michigan. He got the most difficult patients you can imagine, and he wrote a paper that said after 6 months in our clinic on opioids, only about 40% of people are still responding, so don't use opioids in headache. Now, I'm a psychologist. I'm not here to tell you medically or not medically whether opioids should be used in headache. I just said to Joel, though, you have the most intractable headache patients in the world. What else do you do that 40% of people respond to? You know, and so instead, I said, Joel, instead of polemically going out there saying that opioids don't work, how about you go out there and say, these are the characteristics of those 40% of people. These are the people that you should look for if you're going to use opioids in headache, right? And, you know, looking at opioid trials, virtually every long-acting opioid under the sun has an open-label extension safety study for a year. And in virtually every one, 25 to 45% of patients are on stable doses continuing to benefit. So don't tell me there's no data. There's data on every single drug. And look at Jeff Gooden's poster about this at the meeting on Thursday. And I would ask you, if you can get some subset of people on opioids to a year, how many people are really going to develop a problem after a year of stable doses of opioid therapy? We have to figure out who those patients are, because there's no question that careful, judicious use of opioids with pain relief and patient safety in mind is appropriate. And it's not just about exposure. How many MSCs, how many people you use opioids. I'm not going to turn back the clock to 1995 and say that opioids should be first line for everybody. That's absurd. Nothing should be first line for everybody if we're doing this right. But we're treating it as if the drugs are the sole cause of the problem. If we cut down exposures, we'll cut down deaths, we'll cut down addiction. Burroughs was wrong. Addiction is not a disease of exposure. He's a famous heroin addict who wrote the book Junkie. He said addiction is a disease of exposure. Exposure is necessary but not sufficient to create drug addiction. What happens in the people that you can turn into a drug addict are people exposed to a potentially abusable drug who are vulnerable and are at a vulnerable time. Almost everybody we start on opioids is going to have the exposure and they're going to be at a vulnerable time, because they've probably had 6 to 12 months of downward spiral in their function, family members mad at them, giving up pleasurable activities, getting more and more depressed, and then we introduce opioids. And if we do that without understanding their genetic, psychiatric, spiritual, and other risk factors, we're going to have a problem. And those questions often don't get asked. At this meeting, I talked about my shoulder surgery, where I went in, and shoulder surgery, people think, oh, it's acute pain, so of course we're going to give you all the opioids you need. They didn't ask me who I was. My wife is over there going, tell them about the 4 A's. They didn't ask me who I was because it was about my shoulder. It wasn't about me. And, after shoulder surgery, known to be exquisitely painful, by the way, they're willing to give you opioids in some instances up to 3 months. A 3-month opioid exposure in an at-risk person is not trivial. They didn't ask me one question about my history of addiction, not one. They probably looked at me and said, pudgy, nerdy, Jewish guy from Carmel, Indiana, probably not a drug addict. I mean, how many studies do we have in the literature that say that's not how you make that judgment? But we continue to practice that way. And we continue to have some problems. But we have to raise the standard of care, not constantly limit exposures. And we have done it, and we have to do all the exposures better. So here's a paper I wrote with Ken Kirsch years ago. We need to get the drugs in the hands of the people on one side of this graph and keep them out of the hands of the people on the other side of this graph. And then for the people who should have them, we obviously don't give everybody the same care delivery. The adherent person doesn't get the same delivery of opioids or the same drugs or anything as the same way as the little old lady does. We've been preaching this for years. You guys have internalized it, but as a healthcare system as a whole, we have not made allotments for this. If you need 45 minutes to plan this beautiful Da Vinci-esque version of a treatment plan, you need to be paid for the cognitive activity and the analysis and the thought that goes into that. You don't get paid for cogitating in our healthcare system. So some of the myths. Prescription opioids are a gateway drug to heroin. Every day you hear that. I heard Jeb Bush say it, so it has to be true. Exposure to prescription opioids, not necessary nor sufficient, nor is it usually the only drug that people who did make the transition had first. 50% or more of those people were abusing other rewarding drugs before they ever got a prescription drug and then later went to heroin. Ask the governor of Maine how much more they're going to limit MSCs and stop their heroin problem. Focus on exposure. You got a problem with heroin? Torture some pain patients. That'll get it done. Change the laws. Reschedule the drugs. 20% decrease in North Carolina in hydrocodone prescribing since 2012. Look where the scheduling came in. It was already on a downward trajectory for some set of reasons, possibly all the negative media coverage, et cetera, et cetera. Or I would love to put in a policy and kind of catch that roller coaster right there. I'll look like a hero. Did the rescheduling help? I don't know. People probably take credit for it. But one of the things we also know is that rescheduling of hydrocodone occurred on that background, and it renewed and intensified problems for people with pain, destabilizing people who had even long-standing pain treatment with hydrocodone. 10 years or more, and with the rescheduling, some of their doctors just simply took it away. And Jan Chambers and a group of us documented that a couple of years ago when it was first rescheduled. So let's just now quickly go through a couple of studies that I like to refer to, and I mean no disrespect to Argentina, as los desaparecidos, those that have disappeared. from a very black time in the history of Argentina, but these are studies that I think should factor into policymaking and policy and how we deliver care that just disappeared into the ether. So the first one was that Dunbar and Katz one. We all know about Porter and Jick. 11,882 people came into Boston area hospitals, people without a history of addiction, got an opioid during a hospital stay, and only 4 people had documented addiction in their chart after that hospital stay. Never mind that people don't know how to document about addiction. Was there anything true about that? Of course there was. There's an extremely low risk of addiction in non-addicts exposed to opioids for a short time in a structured setting. Is that the same risk as taking those opioids down and putting them in open-ended fashion into young people with histories of polysubstance abuse in southeastern Kentucky? No, we acted like it was because nobody paid attention to Dunbar and Katz. Why would you pay attention to 20 patients when you got 11,882 patients? Forget about the differences. Dunbar and Katz gave people, this was an early study using like electronic monitoring, they gave these patients with a history of substance abuse laptops. So I always figured they weren't terribly serious addicts because they would have hawked the laptops to buy heroin. But they gave them, they recorded their behavior, and in the first week, 11 out of the 20 already had aberrant behavior. So I used to run around back in those days, I'd show them side by side. So the risk of opioid abuse when you get exposed to opioids is somewhere between astronomically low and greater than half. But it disappeared. Everybody acted only as if Porter and Jick was the real story. I'll skip that. I'm going to go to Dasgupta et al. And here's what I said earlier, what I wanted to talk about. In people who died of who got an opioid prescription in the state of North Carolina in 2012, 0.02% actually had a prescription. I'm sorry, 0.02% of those who had a prescription had an opioid overdose, died of an opioid overdose. That means 22 out of 100,000 people prescribed an opioid died of an overdose. I said before, I am not here to say that 22 people's tragedy should be discounted, and I don't mean that, but asking for a sense of proportion. 99,978 people are having difficulty getting their medicine because 22 people died. There's just simply no sense of proportion in this debate. And of course, there's been a lot of focus on this, but 80% of people with pain also get a benzo in North Carolina, and their risk of dying is 10 times higher. We have got to be more careful about polypharmacy, particularly with synergistic effects of CNS depressants. And of those who died, 51% actually had a prescription, and 24% of them had no prescription in the last year. So it brings me to the question, we got to do something about all these overdose deaths. We need safer drugs. We need safer practices. We need Project Lazarus. We need all kinds of interventions. But one of the things that's unhelpful, and I don't have time to go through this in detail, but one of the things that's unhelpful is to take the number to shock and talk about 16,000, 18,000, 19,000, and lump them together as if they're some sort of unitary group. How do you die? You die because you take too much. You die because you raise your dose. You die because your medicine doesn't agree with your medical comorbidities. You combine it with illicit drugs. You take them not as prescribed. You purposely take them to end your life. Lots of people die of opioid overdoses for all kinds of different reasons. And who are they? They're people with a prescription. They're people without a prescription. The ones in red are things that abuse deterrents might help to stop if you alter the route of administration. But how many fall into each category? Nobody knows. But how are we trying to solve this problem? Decrease exposures. Rather than design public health solutions to all of these subgroups and not treat the 16,000 people as if they're all the same. Bob Jamison, one of my heroes, did a study, not to mention Wiedemer and Gallagher and others. And this is a quote from Walter Mischel. Doesn't matter if you have OCD or a histrionic personality disorder, you're about equally likely to stop your car at a red light. In other words, situational variables count. And one of the things that we have to do, if we're going to use opioids safely and raise the standard of care, is that we have to create situations under which patients from those different colors and those different types of people who need pain relief with opioids create a situation that will help them to succeed. And if we can't do that, we can't use, after 30 years of advocating for opioid access, I have to confess that they can be very dangerous if you can't do this. So what did Bob do? And here's the hidden reality. I've been alluding to this. Minimally monitored opioid therapy is only safe and effective for whom it's safe and effective. Everybody else needs a little more. They need to de-emphasize opioids. They need safer drugs. They need more time. They need psych. They need all that kind of stuff. Bob actually tested that in 60 people. These studies are very, very hard to do. What did he show? If you take a high-risk group of patients and you treat them with psychotherapy and monitor them and sit on them, you can take a high-risk group, structure their opioid availability, and you can get their aberrant behavior level down to the same level as low-risk people. The high-risk people that didn't get that had 2 and 3 times more aberrant behavior, so the structure really mattered. Interestingly, no group had none. So everybody needs a little bit of support to take their medicines the right way. This paper should have changed the standard of care. Instead, it disappeared into the ether. Why? Well, I used to try to do it right. I'd get on the phone with a clinician. I'd get on there, I'd say, I want to see this patient more often. We want to do urine drug tests. I want them to have psychological care frequently. I want them to have smarter opioids, abuse deterrence, or something new. I want them to have less drug per prescription. And you know what the answer was? No, 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 copay every time. You've heard me say it before, many of you. The healthcare system is broken. The payers are not incentivizing doing this right and doing it in an individualized way. We have to lobby for it. We have to get this to change. We need to design better opioids that are safer, that don't cause as much respiratory depression and aren't as toxic. We need them to be potent. We need them to have little or no tolerance. We need them to be versatile. We need to get the long-acting opioids off of everybody's 10 most wanted list. How they ended up there, back in the day, guys like Doug and Howard and I advocated when we had complex patients. Long-acting opioids were part of a way to get people to stop overusing short-acting opioids. And somehow long-acting opioids became a problem. And we have to ask the right questions. And I'm going to end by talking very quickly. The wrong question, should we use opioids to treat chronic pain? The right question, in which patients, under what circumstances, at what doses, for how long, with what adjunctive treatments should we use opioids? How can we reduce the supply of prescription opioids? Wrong question. Right question, how do we reduce the excess supply of opioids? What's the excess supply of opioids? I'm not sure. We should have a discussion about that. 60 pills because you had a tooth extraction? Probably not reasonable. And give-back programs should be everywhere. Now they virtually are, but they weren't. And so everybody, still had, hydrocodone in their medicine cabinet from grandma's hysterectomy in 1965. It's still sitting there. Why? Nobody knew what to do with these medications. No one knew how to dispose of them. I'm going to end by reminding us all from a paper that I wrote with Ken Kirsch, my good friend, and Howard Haidt some years ago. We're all stakeholders. Patients, professionals, law enforcement, media, third-party payers. It's become a free-for-all, everybody against one another, pointing fingers, looking to blame other people. We're all stakeholders. And now you have good urine drug testing. You have screening tools. You have PDMPs. You have smarter drugs. You have all kinds of things. We just got to get the healthcare system to let us use them in a way that we can do it in a coordinated fashion. And at the end, I want to ask you, again, we cannot throw in the towel. Our patients haven't, and we don't have the luxury of doing it either. Thank you very much for your attention.
Thanks. Well, thank you, Steve. That was a wonderful speech and covered all of the appropriate issues. It's a lot for us to think about, and thankfully you have a few days in which to do that. I just want to end with a few final housekeeping notes. To help you navigate your way around PAINWeek, your first source for useful and valuable information is our mobile app, accessed at m.painweek.org. Questions can also be directed to any of the PAINWeek and Global Education Group staff who you will find sprinkled around the conference area and at the registration desk. PDFs of the slide presentations and the course evaluations are available online. You will receive an email with a unique link to use to complete your evaluations online. The online evaluation system will be available until the end of September, September 30th, but we would encourage you to do this as soon as possible. You'll be able to print or download your certificate immediately at that time. Also remember to check the electronic meter boards near the main registration desk on this level for any updates and changes in the course schedule. They're minimal, but they do happen. Thank you all for being part of the largest and most ambitious PAINWeek conference ever. I hope you'll join us now down the hallway for the welcome reception in the exhibit hall. Get to know all of the other healthcare professionals and supporting organizations who are dedicated to the betterment of pain education and practice. Thank you all for coming. Enjoy the evening.